If a doctor told you they could, mathematically map the female G-spot, right?
Yeah.
And then they could physically enlarge it with a quick cosmetic injection, you'd probably think they had cured sexual dysfunction forever.
Oh, for sure. I mean, it sounds like the ultimate biological hack. You just add some filler, increase the surface area, and boom, guarantee a result.
Exactly. It sounds completely foolproof. But then you look at the actual clinical outcomes of procedures like the G-shot.
Yeah, the data is, well, it's pretty eye-opening.
It really is. A massive portion of women report absolutely zero change in their sexual arousal after the surgery. So, okay, let's unpack this. Because if modern medicine can theoretically pinpoint this zone, why does physically plumping it up leave so many people feeling absolutely nothing?
Right, that is the million-dollar question.
Welcome to the Deep Dive. Today we're decoding the biological realities of the G-spot to figure out why this augmentation works for some but fails completely for others. And to do this, we're pulling from some really heavy-hitting sources today. We've got clinical anatomical studies, like this pivotal PLOS-1 study on vaginal microvascular density. Plus, we're looking at the latest guidelines from the American College of Obstetricians and Gynecologists, or ACOG, and various medical perspectives on female genital cosmetic surgery.
And what's fascinating here is that the answer has very little to do with the actual physical size of the anatomy.
Really?
Yeah. We really have to look past the cultural myths and, the cosmetic marketing, right down to the highly individualized microscopic neural density of the person. We are looking at unique microscopic nerve maps.
Okay, so before we can figure out why injecting filler into a wall fails for some people, we really need a reality check on what we're actually injecting into, right?
Definitely.
Because for decades, pop culture has sold us this idea of a magic button, like there's a distinct standalone coin hidden somewhere in the tissue just waiting to be pressed.
Yeah, the whole magic button concept is probably one of the most persistent myths in human anatomy. It originally gets its name from Dr. Ernst Grafenberg.
Oh, the G and G-spot.
Exactly. He was a gynecologist studying the role of the urethra back in the 1950s. But modern medical science has completely abandoned the idea of a single spot.
So it's not a spot at all.
Not at all.
Yeah.
When we look at clinical anatomical studies today, it is defined much more accurately as the clitoral urethrovaginal complex. We call it the CUV complex.
Okay, hearing the word complex immediately tells me we aren't dealing with a simple on-off switch here. It's got to be a dynamic combination of structures working together.
Oh, absolutely.
Yeah.
It is an incredibly busy region. There's a fascinating clinical study published in PLOS, one that mapped vaginal microvascular density to actually prove this.
Okay, how did they do that?
Well, researchers took biopsies from the anterior vaginal wall, so the front wall of female subjects, to see exactly where the nerves and blood vessels were concentrated, and they applied this biological highlighter called PGP 9.5.
Wait, a biological highlighter? What does that even mean?
Basically, when researchers apply this specific chemical marker to a tissue sample, it makes every single nerve ending glow under a microscope.
Oh, wow. That's incredible.
Yeah, it's amazing. It allows us to see exactly where the body's wiring is concentrated,
Yeah.
completely bypassing any guesswork, so they don't have to guess where the sensitive parts are.
Right, because it's literally glowing. So what did they find?
The results showed that the distal third of the anterior vaginal wall, so roughly 1 to 3 inches inside the vaginal opening, has significantly richer small nerve fiber wiring than the deeper sections.
Okay, so there really is a massive cluster of nerve endings in that specific shallow zone. But I imagine it's not just nerves hanging out in empty space, right?
Right, exactly. They're deeply intertwined with other structures, specifically the urethral sponge and Skene's glands.
Skene's glands.
Yes. Skene's glands are actually homologous to the male prostate gland. Some people call it the female prostate. During sexual arousal, these glands and the surrounding spongy tissue fill with blood and fluid.
Oh, okay. So they physically change during arousal.
Yes, they swell, creating this highly sensitive, engorged area right against that nerve-dense wall.
Okay, so instead of thinking of the G-spot as a single light switch on a wall, it's more like a busy traffic intersection where the vaginal wall, the urethra, and the internal roots of the clitoris all meet and exchange signals.
I love that analogy.
Yeah.
It is exactly like a busy traffic intersection.
Yeah.
And stimulating this intersection is what actually triggers the complex neurological response we associate with the G-spot.
Right.
When pressure or friction is applied to that area, you are sending mechanical signals through a whole web of intersecting tissues, blood vessels, and nerve roots. The traffic isn't just moving in one direction.
It's all connected.
Exactly. It's a massive, coordinated signaling event heading straight to the central nervous system.
Okay, well, if this neural traffic intersection is so crucial, it completely explains why women have such radically different experiences. Because unlike a skeleton, which is, mostly identical from person to person, I'm gathering this intersection is a total genetic lottery.
It is the absolute definition of biological diversity.
Yeah.
I mean, to understand why, we really have to look at the internal anatomy of the clitoris, which for a long time was a glaring blind spot in anatomical textbooks.
Which is wild.
It really is. We didn't have comprehensive maps of it until MRI imaging became sophisticated enough. There was this groundbreaking imaging research by Dr. Helen O'Connell, and it showed that the clitoris isn't just the external glands we typically think of.
Right, there's more underneath.
A lot more. It has these massive internal roots or legs called the crura and the vestibular bulbs that extend deeply into the pelvis.
Which is just wild to think about. We map the entire human genome before we fully map the internal structure of the clitoris.
Yeah, we were looking at a fraction of the picture for centuries. And these internal roots actually wrap around the urethra and the vaginal wall. But the really critical finding from the imaging is that these roots vary wildly in size, shape, and proximity from one person to the next.
So in some women, these large clitoral roots wrap extensively around the anterior vaginal wall, creating this massive, highly sensitive intersection. The nerves from all these structures are practically woven together.
Exactly. And in other women, those internal structures are smaller, or they sit further away from the vaginal wall. There is physically just less overlap.
And I assume that structural variation directly impacts the nerve layout, right?
It absolutely does. Another researcher we looked at, Dr. Thabet, found that while the general tissues of the CUV complex are present in everyone, the actual nerve concentration is highly localized, meaning dense and distinct in only about 58% of women.
Wait, only 58%, meaning 42% of women fall into a totally different category.
Exactly. In that 42%, the nerve distribution is what researchers call diffuse. The nerves are spread out, they're much less concentrated. There is no single prominent hub of sensitivity on that anterior wall.
See, here's where it gets really interesting. If 42% of women have a completely diffuse nerve layout and clitoral roots vary in size, then the textbook G-spot doesn't actually exist for almost half the population.
Right. It's a complete myth for nearly half of all women.
It's not that they're broken or dysfunctional, it's just that their traffic intersection is designed differently. The roads don't all cross in that one specific spot.
That is the biological reality. And this raises an important question. How do we treat a lack of sensation when the baseline anatomy is so fundamentally varied? Because to add another layer of complexity, this baseline genetic variation is heavily influenced by age and hormones.
Oh, of course. Hormones play a huge role.
Huge. Returning to that PLOS1 study, researchers didn't just map nerves. They look at the microvessels, the tiny blood vessels supplying the area using the SMA marker. And they found a stark difference when comparing premenopausal and postmenopausal women.
That has to be driven by the drop in estrogen, right?
Exactly. Estrogen is essentially the biological fertilizer for this tissue. It maintains the collagen, the elastin, and the intricate web of microvessels. When estrogen drops during menopause, the body basically stops prioritizing that tissue. The microvessels literally shrink. They just can't deliver as much blood or oxygen to the area.
And if the blood vessels shrink, they can't support the nerve endings. The nerves are basically starving.
Yeah, they lose their life support. This leads to vaginal atrophy. The tissue thins out, and the actual neural density decreases. So a woman's neural map isn't just unique to her genetic blueprint. It actively morphs over her own lifespan based on her hormonal state.
I mean, this raises a massive question about how modern medicine approaches sexual wellness. If the baseline anatomy is this fundamentally varied and constantly shifting based on hormones, treating a perceived lack of sensation seems incredibly difficult.
It is.
You aren't fixing a standard broken bone here. You're trying to navigate a map that changes shape depending on who you're looking at and how old they are.
Right. This natural variation in nerve branching and cross-innervation means sensitivity is entirely subjective to the individual's genetic blueprint. There is no one-size-fits-all anatomical standard, even though we often try to treat it that way.
And that brings us directly to how the cosmetic industry is attempting to navigate this map. Because society places so much pressure on experiencing very specific types of climax specifically, the vaginal orgasm and entire aesthetic industry has emerged to fix this natural variation.
Fix it, in air quotes, of course.
Right, fix it. The pitch is basically, if you can't find it, we'll build it for you.
Yes, we are talking about G-spot amplification, which is commonly marketed as The G-shot.
The G-shot.
Yeah, it's a physician-administered cosmetic treatment. The process involves injecting a filler, usually a human-engineered hyaluronic acid, which is the exact same type of substance used in facial or lip fillers, directly into that distal third of the anterior vaginal wall. Or sometimes they use collagen.
Okay, let me make sure I'm picturing this correctly. A clinician locates the supposed area of the G-spot and just pumps it full of hyaluronic acid. The goal isn't chemical, right? It's purely mechanical. They are just trying to add volume.
Exactly. The clinical aim is to bulk up the tissue, often describing the target size as roughly the diameter of a 5p coin. By increasing the thickness of the tissue, it projects further into the vaginal canal.
So it just sticks out more.
Right. The logic relies on simple physics. A larger, more prominent physical bump will theoretically create more friction and contact during penetrative intercourse.
And it's an outpatient procedure, too. Our sources say it takes about 20 minutes, requires local anesthesia, and the results last anywhere from 3 to 6 months before the body naturally absorbs the filler. It's marketed as this quick lunch break fix for sexual enhancement.
It is heavily marketed that way, which makes it very appealing to patients who feel like they are missing out on a standard biological experience.
I mean, if a woman is struggling to find this zone, making it physically larger sounds like a logical fix. Why wouldn't you want more surface area? More friction should equal more feeling. But looking at the literature, I'm seeing some wild discrepancies. Does it actually work?
Well, the data is deeply polarized. If you read the promotional literature from the clinics providing the service, they report incredibly high satisfaction rates. There's one pilot study frequently cited by these clinics claiming 87% of women reported enhanced sexual arousal and gratification after receiving the G-shot.
87% sounds like a massive success rate. But I imagine the mainstream medical community must look at that number with a lot of skepticism. Clinical trials for cosmetic aesthetics aren't exactly known for their rigorous control groups.
Right, exactly. The broader medical community at large is highly skeptical, largely because studies boasting those numbers often lack placebo controls, they lack long-term tracking, and they have very small sample sizes.
And the placebo effect is a real thing.
Oh, it's huge. When a patient pays thousands of dollars out of pocket for a procedure they desperately hope will improve their sex life, the placebo effect can be extraordinarily powerful in the short term. The self-reported data from a small, for-profit clinic is just not the same as a peer-reviewed, double-blind study.
Which brings us back to our central paradox. If we look at the clinical anatomy we just discussed and layer this cosmetic procedure on top of it, we finally hit the reason why a bigger bump doesn't guarantee more pleasure. It explains the non-responders.
Exactly.
Hyaluronic acid adds volume, but it doesn't add nerves.
You cannot inject a nervous system from a syringe. Think back to Dr. Thabit's finding that 42% of women have a diffuse nerve layout.
Right, the spread out nerves.
Yes. If a woman's internal clitoral roots do not deeply intersect with that specific anterior wall, she fundamentally lacks a dense cluster of sensory receptors in that location.
So what does this all mean? It's like building a massive extension on a house, but forgetting to run electricity to it. You've got a bigger room, it takes up more physical space, you can definitely see it, but the lights still won't turn on. Volume without neural density is sexually meaningless.
That is a perfect way to put it. It is an empty room. Plumping up that tissue with filler is just plumping up an area with low neural density. You are creating a bigger physical bump, but there are no extra nerve endings inside that bump to capture the friction and transmit pleasure signals to the brain.
Wow.
This biological reality is exactly why major medical bodies push back so hard on these procedures. I mean, the American College of Obstetricians and Gynecologists, ACOG, issued a very direct committee opinion on this, opinion number 795.
I imagine they must be terrified by the idea of injecting fillers blindly into a highly vascular area.
They are. Their guidelines explicitly state that cosmetic procedures like G-spot amplification lack high-quality data to support their effectiveness, and they are not medically indicated for altering sexual function. Furthermore, they highlight severe potential risks.
Like what? What are the risks?
We are talking about altered sensation, meaning a patient could actually lose what little feeling they already have. Also scarring, dyspareunia, which is painful intercourse, and serious infections.
So not only might you be paying for an empty house extension, but the construction process could actively damage your existing wiring.
Exactly. ACOG warns that marketing these procedures as guaranteed rejuvenation or a cure-all is misleading because it treats human sexuality like a purely mechanical issue. You cannot inject nerve endings. It ignores the central nervous system entirely.
And it ignores all the other physiological and psychological factors that our sources highlight. I mean, even if a woman is in the 58% who have a highly localized nerve-dense intersection, if she has severe pelvic floor tension or vaginal dryness from a lack of estrogen, or if she's just experiencing high stress, a hyaluronic acid bump is not going to magically override the brain.
The brain is the ultimate sexual organ. It acts as a gatekeeper. If the central nervous system is stressed, or if there is vascular insufficiency, it will literally gate off pleasure signals, regardless of how much physical friction is happening in the CUV
All
complex.
right.
A localized filler injection completely bypasses the complexity of vascular health, hormonal balance, and psychological well-being.
It feels like the medical aesthetics industry is trying to force a one-size-fits-all anatomical mold onto a population that is, quite frankly, wildly diverse. If your biology is already primed with a dense nerve cluster in that exact spot, maybe the filler adds just enough mechanical friction to push you over the edge.
Maybe, yeah.
But if you have a diffuse layout, the clinics are leaving you feeling broken or inadequate when your unique anatomy simply doesn't conform to their specific syringe.
If we connect this to the bigger picture, treating sexual sensation as a purely mechanical issue just ignores biological reality. The clinics are essentially taking credit when the biology was already primed to respond and offering no real solutions for the incredible diversity of the human nervous system.
So pulling all these sources together, the G-spot, or the clitoral ureterovaginal complex, is a highly innervated, very real zone for some people. But its sensitivity is dictated by a deeply personal microscopic neural map.
Yes.
Enhancing it with fillers might provide more physical friction, but it absolutely cannot rewrite your nervous system.
The biology is real, but the natural variation is vast.
Which means if you're listening to this and you've ever felt frustrated because you don't respond to typical stimulation, or you can't find this magical button the magazines talk about, remember that biological variation is not a dysfunction.
Exactly.
If you don't have that specific localized nerve density, it simply means your unique neural map requires a different approach to pleasure. You don't need a medical intervention to fix a system that isn't actually broken.
It's about discovering your own anatomy, rather than trying to medically alter it to fit a cultural expectation. And, this makes me think of a final thought here. As medical imaging technology like functional MRIs continues to improve, it gets incredibly exciting.
Functional MRIs.
Yeah, researchers are beginning to map the brain's real-time response to genital stimulation. What if the future of sexual wellness isn't about blindly injecting fillers into a hypothetical zone to fit a standard mold?
Okay, I like where this is going.
What if instead the future is about non-invasive imaging that actually maps a woman's unique individual neural pathways?
Wow.
Imagine a diagnostic tool that doesn't try to fix you, but simply shows you exactly where your own electricity is truly routed, allowing you to finally understand your body's custom blueprint.
Now that is a map worth exploring. Thanks for joining us on this deep dive into the muddy waters of human anatomy. Keep asking questions, and we'll catch you next time.